I was fortunate to attend the very first John Conley lecture in 1986 in San Antonio and meet Dr. Conley. Since then, it has been an anchor presentation at our meetings. This year's presenter, Andrew G. Shuman, MD, is an associate professor in the Department of Otolaryngology at the University of Michigan Medical School. He serves as chief of the Clinical Ethics Service in the Center for Bioethics and Social Sciences in Medicine, and is the associate chief of staff at the VA Ann Arbor Health System. Dr. Shuman is recognized as a thought leader in ethical issues within surgical oncology and otolaryngology. His work centers around defining the conceptual dimensions of surgical ethics by applying his perspective as a practicing surgeon and clinical ethicist to normative and empirical bioethics research. He completed fellowships in head and neck surgical oncology at Memorial Sloan Kettering Center and in medical ethics at the Weill Medical College of Cornell University. Completed his residency in medical school at the University of Michigan. He will serve as the Academy's Ethics Committee Chair beginning October 1st. And now, the Conley Lecture.
Welcome to an exploration of ethics as shared by preeminent thought leaders. Welcome to the John Conley MD Lecture on Medical Ethics. For over 3 decades, thought-provoking topics on medical ethics and the field of otolaryngology, head and neck surgery have engaged, inspired, and continuously advanced a dedication to patient care. The 2022 guest lecturer of the John Conley MD Lecture on Medical Ethics joins a distinguished group of thought leaders, exemplary medical professionals, and humanitarians. Please welcome the 2022 John Conley MD Lecture on Medical Ethics guest lecturer, Dr. Andrew G. Shuman.
Good morning. It's truly my pleasure to be with you today. The words that I'll be sharing today are my own, and I don't have any relevant disclosures related to this talk. First, I just want to acknowledge the enormity of this humbling honor and thank Dr. Donati, Dr. Yanagisawa, the Board of Directors, the Academy itself, my mentors, my friends and my family for all of their support, and I truly am blessed and honored to be with you today. Dr. Conley's legacy carries on and shines through. It has informed my career, my academic interests, and I know many of your surgical practices as well as the way you think about how we take care of patients. And it is absolutely an honor to honor his legacy today. Finally, we've taken a moment of silence already, but I also simply want to recognize the fact that literally 21 years ago at this very moment, 4 airplanes were hijacked and on their way to devastation and disaster in a way that changed the world. I want to honor the memory of those we lost, as well as those heroes that emerged that fateful day. So it's been a long road. The last 3 years have been challenging and hard in ways that are unique and different than really anything we've experienced in the past. We have traveled this road together, and what I would argue is that the practice of medicine has fundamentally changed because of extrinsic forces that have gotten in the way of what we do for the patients entrusted in our care. And the way we practice now is in many ways bounded by forces outside of our control in a way that is profoundly uncomfortable for clinicians. The way we need to deal with this is by being honest, being open, and talking about contentious and difficult issues as a community of health scholars and healthcare professionals. And also being able to respectfully disagree and share opinions with each other as well as with our patients in ways that move conversations forward. The crux of my message today is that we need to transcend the political silos of this age in order to refocus upon the patients and their needs. Again, it's been a long road. At the start of this pandemic, many of us were dealing with uncertainty about our own health and safety as we were scrambling to take care of people with a disease we didn't understand, with risks that we couldn't really fathom. And at the same time, deal with patients like this man who was devastated by needing to postpone a necessary cancer operation. And of course, this applies to many other subspecialties as well. Fast forward, and we were dealing with a contextual situation in which there were political and other perspectives on what was appropriate or not appropriate with regard to social distancing, with regard to mask wearing, with regard to all of the things that we were desperately trying to do to keep each other safe. Things changed a bit when we finally came up with the beginning of the solution to this plague with vaccines. I think we all recognize just the enormity of how important that has been, but also recognizing that it was very difficult for many people to recognize, appreciate, and adopt the public health interventions that we so desperately rely upon. And finally, as we approach some degree of normalcy now, looking out on a full room, knowing that we're safe and we're protected, we also have to recognize that there are people who are not feeling safe or protected and the needs that they have. So the crux of this really, for me, comes down to trust. And the best definition of trust I've seen is the optimistic acceptance of a circumstance of vulnerability. And the enormous weight of responsibility that falls on us is prefaced by the fact that our patients trust us. We are providing wisdom, we are providing compassion, we are providing information, and we are providing care to people who are at their most vulnerable. And that is truly something that we can never take for granted. Vis-a-vis vaccines, I'll speak a bit about the COVID vaccination issue. Early after the vaccine first came out, a Lancet commission put out a beautiful piece talking about just how important it was to get the COVID vaccine in arms across the globe. And this was challenging in many respects, from a logistical standpoint, from a practical standpoint, and of course, convincing people that this was the right thing to do. This paper put out a beautiful table, which I don't expect you to read, going through all of the necessary details and nuances of what the public health effort needed to be to get doses in arms. And again, this was right when the vaccine came out. But what's most important is not that table or anything else in that piece, but rather this sentence. We need public trust, and we need to be able to convince people that what we are doing is for them and for us as a collective society. There's many ways of doing this, and there's some wonderful tips and guides for how to have hard conversations with people who might not agree with us. And this applies not just to vaccination, but to many other things in terms of individuals who may not necessarily buy into what our recommendations as clinicians may be. The NIH has a lovely communication sheet, and for those who are unaware, there's a COVID handbook which actually provides scripted language to help have conversations with people who may be diametrically opposed to what we believe or what we think or what we recommend. Many of these words and many of these messages apply far outside of the context of vaccination. My friend and colleague, Dr. Hogikian, and I wrote in our white journal about this issue. We talked about how divisiveness and politicization are challenges that we need to face head on, and that wearing a mask or getting a vaccine is not a litmus test. It is not a statement of your political will or a position that requires anything other than recognizing who we are as a community, who we are as a society, and what we need to do to protect each other as well as ourselves. So the way to approach vaccine hesitancy or any siloed perspective is through sharing humanity, having conversations. And we are in an era right now where taking care of the patient in front of us is critical, but also making it clear to that individual that we are a society rather than individuals. So the way to have these conversations is by asking people to tell us more. Why do you feel the way you do? Help me understand your perspective. Explain to me where you're coming from. What are you afraid of? What can we talk through? Those conversations reframe issues in a way that is less adversarial and thereby productive. And I would argue that creating litmus tests of you need to be vaccinated in order to receive care are anathema to who we are. Once we get into a situation in which we're making requests that become requirements, really we've lost that game. And we know how to do this. In otolaryngology, we take care of people who have conditions related to health behaviors every day. We take care of folks who smoke with head and neck cancer. We take care of vocal overusers with dysphonia. We take care of folks with repeated facial trauma. Health behaviors always will inform our practice, and we know how to talk to people about hard things with which they may not necessarily like what we have to say. I'm very proud of our academy to have come out with a strong position statement on the issue of vaccine hesitancy, specifically discussing how we have a collective obligation to provide care that is not based upon vaccination status or anything else. I'm going to transition now, and this may seem abrupt, but the overlying theme here is one of transcending politics in a way to refocus our efforts on the patients in front of us. As many of you are aware, the Supreme Court this past summer came out with a decision in the Dobbs versus Jackson case that essentially removed pre-existing protections to the right to abortion in our nation, relegating these decisions to the states. I am not here to tell you my views on the morality of abortion. I am not here to convince you to change your mind. And I am not here to talk about when life begins. I am here to talk about how this impacts our field in ways that we might not necessarily comprehend, and in ways that require us to take positions and understand the enormity of this sea change in our nation. And I'll give you some examples. So Tanya is a 30-year-old woman who is absolutely thrilled that she's 11 weeks pregnant and desperately wants a baby. But she's diagnosed with a T4 oral tongue cancer and recognizes that she's going to need a massive operation and adjuvant treatment thereafter. She wants this baby, but she also wants to live, and she's petrified about the choices that face her. Ashley is a 24-year-old woman who has autoimmune disease and very severe subglottic stenosis, for which she's had multiple dilations, and is doing everything in her power to avoid a trach and other complications of her condition, and has been told in no uncertain terms that a pregnancy can dramatically impact her autoimmune disease as well as her airway status. She did not intend to get pregnant and is similarly petrified about what choices await her. And finally, the Smith family. The Smith family is excited about the birth of their son. They're at 20 weeks, and on their 20-week ultrasound, they're devastated to find that their son has massive craniofacial abnormalities and airway concerns that are likely incompatible with life, and have some very hard conversations with their pediatrician, their OB/GYN, their pediatric otolaryngologist, and a neonatologist about what options they have. So the point that I'd like to make is that Dobbs impacts our field and can and will impact our practice. So the implications of Dobbs mean that different states and local jurisdictions can and will interpret and change the way the law is enforced and written in ways that may change on a dime. And this is confusing and complicated and will beget inequities in care and create different standards in different places. This is going to require doctors, as was recently quoted in the lay press, to have to think like lawyers. And I would argue that that is a problem. Many of these laws in individual states that are restricting access to abortion include specific protections for life and or health of pregnant people. However, these are very difficult to interpret, have yet to be tested by the courts, may or may not be enforced by local jurisdictions, and mean that clinicians are in a very significant amount of legal jeopardy based upon their actions, and that includes us. ACOG, as well as ACS, as well as many other professional organizations have taken varying stances on this with varying strengths. I'm not going to summarize them in depth other than to say that many societies related to our work have raised concerns in terms of how DOBS will impact our field. I was privileged to help work with my co-editors at The Oncologist and the Society for Translational Oncology to discuss the impact of this upon pregnant people with cancer, many of the thoughts of which are expressed in this talk today. I would again reference Tanya, who has oral tongue cancer, as a poignant example of how we are not immune to these conversations. So our professional obligations, in my opinion, require us to facilitate access to care and do our utmost to make sure that patients know what rights they have, what options they have, and what their potential route forward may be, making what will undoubtedly be some of the hardest decisions of their life. And at the heart of this is not the law and is not regulation, but it's the relationship that we have with our patients and that trust that's instilled in everything that we do. And I am concerned, along with many others, that the DOBS decision can potentially limit the clinical options available to people who are so desperate for knowing what options are on the table and how to be able to act. So as otolaryngologists, many of us are protected, at least to some degree, because of our practice, frankly. But not all of us. And this will come up. This will come up in ways that are not necessarily predictable and in ways that are absolutely predictable. So I would encourage us to think about these and understand that in some states, any act that is perceived as aiding or abetting an abortion, even in specific situations to protect the life and health of a pregnant person, can put us in legal peril. So what should we do? We need to talk. We need to be honest with ourselves, with our colleagues, with our patients. And I would suggest that we need to help draw very clear lines in the sand about what clinical situations require us to protect the health of pregnant people, to allow those pregnant people to make very difficult choices in a shared decision-making model. We can and we should guide the courts and lawmakers and others in interpreting and understanding what these impacts may look like upon our practice and our field. And we need to advocate. I would argue that we should not allow our family planning colleagues and women in general to not recognize that we have thought about some of these issues as well and are there to support them. And we really need to unite to recognize that pregnant people with health limiting issues, specifically related to our field, can and should have certain choices that are being taken away in certain settings. I'd like to conclude by shifting gears a bit and talking about Dr. Anderson Abbott. Dr. Abbott was the first Canadian surgeon who received his ability to practice and his license in the early 1860s in Canada. Recall in Canada, slavery was abolished 30 years before it was in the United States. And when the Civil War broke out, he realized that he was needed to take care of people, and it wasn't in Canada. So he crossed not only the US border, but the Mason-Dixon line, and worked as a civilian volunteer surgeon at Freeman's Hospital, which is just outside of Washington, D.C., and is still there now, is actually part of Howard University. And during the Civil War, he took care of Northerners and Southerners and freed slaves because it was the right thing to do, recognizing the peril that he put himself in. Along the way, he became friendly with Abraham Lincoln and worked within the circles in D.C., and eventually, after the war, returned to Canada, where he had a successful surgical practice and worked on issues of civil rights and reconciliation in his home region and country. Dr. Abbott was able to transcend politics, to do the right thing, and take care of his patients. I suggest we take a lesson from him and we keep this conversation going and recognize the enormity of our responsibility, as well as the importance of our voice in articulating the needs, desires, and requirements for practice in order to protect the patients who are entrusting their lives in our hands. It is my true honor to be here with you today. I thank you for your time and attention, and I wish you a good meeting.